Thank you, Professor Zhu, for the very nice introduction. Dear Professor Lily, nice to see you again. Last time is in ESC in Netherlands. It's my pleasure to be here to give a talk about shall we try to lower TG-rich lipoproteins, which is given by the forum. And I try to answer the tough question. First of all, what's TG and the team it leads? TG is the most abundant lipid in the human body, composed of long-chain fatty acids and glycerol. Most tissues can use the products of TG to provide energy. Account of the hydrophobic nature of TG, it must combine with associated lipoproteins into lipoproteins that allow it to transport in the plasma. The major lipoproteins combined with TG include VLDL when TG is mild to moderately elevated, strongly associated with CV risk. Another lipoprotein is chylomicron when TG is severely elevated, mainly related to acute pancreatitis. In clinical setting, non-HDLC reflect the cholesterol contact found in all potentially atherogenic lipoproteins, but principally in LDLC, LDL, and VLDL remnants and chylomicron remnants. Because in the clinical lab, they could not directly test VLDL chylomicron, so have to use non-HDLC to cover the TG leading CV risk. So what's the atherogenic mechanisms of TRL? When TG is severely elevated, the chylomicron is still too large to enter the endothelium, but their residue particles can enter the endothelium just like LDL after lipolysis. TG depleted by LPL to form free fatty acids, causing local inflammation and promoting monocytes to form foam cells. When TG is mild to moderately elevated, TG in VLDL are transferred to LDL by CETP, and meanwhile, the cholesterol in LDL is transferred to VLDL, which is then hydrolyzed by LPL into VLDL remnants. The size of VLDL remnants particles can be reduced and pass through the arterial wall. LDL-TG becomes small dense LDL after TG being hydrolyzed by LPL. Influx and retention of small dense LDL into arterial walls more easier and longer, which promotes atherosclerosis. So what's kind of a relationship between TG, TRL, and the risk of SCVD? Studies have reported an association between elevated TG level and SCVD. Actually, the association is attenuated after adjustment for HDLC level. This is a kind of argument for TG and SCVD risk. But serum TRL are consistently associated with SCVD risk and independent of other metabolic disturbance. Let's get to know remnant lipoproteins and remnant cholesterol. That's a different two identification, but help us to understand what happened when TG elevated. Hydrolysis of TG in the core of chylomicrons and VLDL by LPL leads to the formation of TG depleted particles termed chylomicron remnants and VLDL remnants respectively, and give a specific name as RLP, remnant lipoproteins. And this is actually a dynamic product of ongoing lipolysis of both chylomicrons and VLDL. Another named RC is the remnant cholesterol. Cholesterol in RLP is called remnant cholesterol RC. RC level is strongly consistent with TG. That index is about 0.96, which is closely associated. If you try to calculate remnant cholesterol equal to non-HDLC minus LDLC, then we got to know if TG elevated, that demonstrates the TRL particles elevated, and remnant cholesterol elevated as well. And then non-HDLC cover LDLC and VLDLC. So non-HDLC usually increased, and then leading to residual CV risk increased. If the TG elevated severely, that will cause acute pancreatitis. So TG actually is not a maker. TG is a marker. It's kind of a whistler of SCVD risk. As we know, despite significant LDLC lowering with starting therapy, 60 to 70% residual CV risk still there, and the residual risk usually thought to be in part due to inadequate reduction of LDL, and others are due to lipid profiles, except LDL-C is strongly associated with atherosclerosis, such as TRL. So only focus on LDL and ignore other pathogenic factors like TRL or remnant cholesterol will be dangerous ahead. A lot of studies, including genetic study and epidemiological studies, showing that TG is related to SCVD. Genetic studies confirm high TG as a risk factor of atherosclerosis. Some data from Copenhagen City Heart study showed genetically TG and remnant cholesterol were doubling in concentration. Then risk of myocardial infarction increased about 94% and 123% respectively. And another study also from DASH, general population, elevated remnant cholesterol was associated stepwise with increased ischemic heart disease, myocardial infarction, and all-cause mortality risk. The study also showed that remnant cholesterol as a causal risk factor for ischemic heart disease. Remnant cholesterol increase of 1 millimolar per liter is associated with a 2.8-fold causal risk for IHD. A relative new data showed remnant cholesterol more than 30 differentiated subjects at a higher risk of MACE compared with those at a low concentration, regardless of whether LDL achieved the goal or not. VLDL-C accounts for 1/2 of risk of myocardial infarction associated with ApoB-containing lipoproteins, published by recently journal, which is quite out of expectation. VLDL-C explained 1/2, but the LDL-C at ideal only explained less than 30% of risk of myocardial infarction from ApoB-containing lipoproteins. That means actually VLDL may did bad things or worse than the LDL in some population and within some situation. So from the physiological mechanism, epidemiological study, and genetic study, TRL is significantly correlated with SCVD. Then how to manage TG or TRLs and get CV benefit? Now we can see clinical accessible TG lowering drugs include fibrates, omega-3 fatty acids, niacin. Niacin, it's kind of a tragic medication. Almost all of the clinical trial showed a negative data for CV benefit. So it's basically dead in CV benefit and prevention of CVD risk. How about the fibrates? The phenobarbital-related clinical trial only shows some positive data in subgroup analysis and meta-analysis. So for the whole picture of RCT, it's negative. There are several real-world studies published. One is real-world study in Korea showed adding TG lowering therapy on starting reduced the risk of MACE in patients with metabolic syndrome. That is from Phenobate. Real-world study also showed that patient can achieve more benefit with high TG and low HDL-C in metabolic syndrome. We have to deal with a prominent study that's a quite argument and a hot spot recently. This study tried to explore if triglyceride lowering with pemafibrate can reduce CV risk, but unfortunately, the result is negative. A patient with a type 2 diabetes, mild to moderate hypertriglyceridemia, and the low HDL and LDL-C levels, the incidence of CV events was not lower among those who received pemafibrate than among those who received the placebo. Even we can see the pemafibrate lowered TG, VLDL-C, remnant cholesterol, and ApoC3 levels significantly. If you look at the lipid profiles, you will see LDL-C and ApoB after treatment increased significantly, about 12% and almost 5% in this study. So here are some key points of revelation from PROMINENT. The data from the PROMINENT trial are consistent with increased efficiency in conversion of TRL remnants to LDL rather than their removal by the liver. The lack of benefit shown in the trial suggests that beyond the effects on TRL remodeling, enhanced clearance of TRL remnant particles from the circulation rather than their conversion to LDL particles may be needed to abrogate the atherogenic effects of more remnants in patients with high TG. These issues may be clarified in ongoing trials of agents that use alternative pathways to lower level of TG and remnant particles, including inhibition of ApoC3 and NGPTL3. So I would like to give a quick tips about this part. The studies of pemafibrate only showed positive results in subgroup analysis and a meta-analysis about the CV benefit. The study of pemafibrate significantly reducing TG level but not achieving CV benefit was terminated. But these results of fibrate studies cannot be extrapolated to omega-3 fatty acids and other TG-lowering drugs. How about omega-3 fatty acids? Before 2017, actually, omega-3 fatty acids, the recommendation for it is not that high. We can see the degree by guidelines and statements, but until REDUCE-IT study published. This study includes patients with actually 70% secondary prevention and 30% primary prevention with higher TG level, and finally get positive and surprising results. EPA achieved 19% reduction of TG and reduced the primary endpoint by 25%. So if you see the analysis later, the result showed that CV benefit is not dependent on baseline TG levels. After 1 year, there was no difference between primary and secondary endpoint by achieved TG level, no matter above 150 or under that. Both were benefited. So if you look at the baseline of TG, you will see no matter the baseline is higher or lower, the CV benefit is quite similar, so no significant difference intergroup. EPA-related sub-analysis showed that there was a strong negative correlation between the tertile of EPA and the reduction of CV events in the IPE group. And later, when the data of two groups were summarized and analyzed together, this strong negative correlation was still there. That's kind of make more sense about EPA level. So CV benefit from IPE is mainly due to elevated EPA, TG lowering, and other pleiotropic effects contribute only a part. Then take a look at strength study. Actually, the strength study design is quite similar as REDUCE-IT. They include primary and secondary people mixture population and use omega-3 fatty acids also 4 grams per day, but the gradients is different, EPA and the DHS, not EPA alone. But the endpoints were not met. That's negative results. But if you take a look at the TG reduction is about 90%. It's quite similar. REDUCE-IT, that's achieve 0.3% TG reduction. It's quite similar. But one is positive data, one is negative we just take a look at other important lipid profiles like non-HDL-C ApoB. Okay, they quite similar between them. And if you convert the TG reduction to ApoB and followed by CV risk in terms of genetic study, if TG reduction about 70, that convert into ApoB 10 milligram per deciliter, that will achieve 23% CV risk reduction. Let's take a look, reduce it and strength. 39 reduction in TG, ApoB only 2, and the CV benefit is 25%. So it's definitely the benefit is not from TG reduction in reduce it. And how about strength? 48 TG reduction, 1.3 ApoB, and no CV benefit. So this is actually no matter TG reduction more or less, actually it's benefit from EPA level alone. CV benefit from lowering TG may depend on adequate reduction of ApoB, but these two trials didn't show any ApoB significant reduction and achieve CV benefit. ApoB reduction was so limited, so it's not about the TG level or TRL. Another brand new study published recently showed that an increased risk of all-cause cardiovascular cancer and other mortality with higher TG metabolism. But this study, this association was not explained by higher plasma TG and BMI. This is an observational study that can only determine a correlation between the risk and the TG metabolism, but not a causal relationship. So we already know omega-3 fatty acids can reduce TG, but the CV benefit is not just from TG reduction. It's majorly not from TG reduction, from the absolutely EPA level, because they have multiple functions, including like anti-inflammation, anti-thrombosis, antioxidative strength, and stabilized plaques, and multiple functions contribute to the final CV reduction, CV risk reduction. So about how to lower the TG and get the CV benefit, what's the key points? Actually, the proportion of TRL and remnant cholesterol in atherogenic lipoproteins is relatively low, and a significant reduction may be required to achieve CV benefit. A significant decrease in TG does not necessarily mean a decrease in TRL and RC of the same strength. It is necessary to significantly reduce the lipid particles containing ApoB in order to reduce CV risk. This is the key. Then how to manage TG and its team by guidelines and statements recommendations. First of all, look at the Europe guidelines. TG and the non-HDL-C both are risk factors for risk estimation, and if TG under 1.7, that's quite safe for CV risk, but above 1.7, that indicate a need to look for other risk factors. Non-HDL-C as a secondary treatment goal, especially in some metabolic syndrome, diabetes, high TG population, LDL-C, extremely lower patient. Lifestyle change is still background treatment, and the starting treatment is recommended as the first drug of choice to reduce CV risk in higher risk individuals with high TG more than 2.3. But here for omega-3 fatty acids recommendation, that's a little bit different by IPE and EPA and DHA. In high risk and above patients with TG between 1.5 to 5.6, IPE recommended. And if others, we can cut the TG point as to more than 2.3, then can use phenobarbital and omega-3 fatty acids to reduce the TG and CV risk. How about China guidelines? The new China guidelines recommended non-HDL-C more than 5.2 as a risk factor for CV estimation of the rest life. Here, I just mentioned the non-HDLC covered LDLC and VLDLC, which actually TG reflects the VLDL particles increased. So here using the clinical set non-HDLC, but a high TG more than 2.3 is one of the risk enhancer of SCVD in these new guidelines. And non-HDLC is very important intervention target, although it is a secondary target, but for the patients with mild to moderate elevated TG, type 2 diabetes, metabolic syndrome, and extremely low LDL-C level, it could be the first one replace LDL-C as the primary target. And the TG right now, the status in the guidelines, TG as a target for management, but not for treatment, because at least lack one whole picture of CVOT trials. The recommendation for treatment actually is quite similar as that in European, but only the cutoff. European has two different cutoff, 1.5 and 2.3. In China guidelines, it's 2.3 as for total residual CV risk reduction, whatever using EPA, DHA, and final baits, but the different recommendation degree is suggested. So finally, I will go back to the very beginning. Shall we try to lower TG-rich lipoproteins? My point of view is there is no conclusive evidence to suggest that the reduction of SCVD risk by omega-3 fatty acids are directly related to TG lowering. The CV benefits for omega-3 fatty acids may come from multiple effects, and the contribution of reducing TG is difficult to be quantified. There was subgroup analysis and meta-analysis results showing that phenobarbital can reduce CV risk while reducing TG, but there is still lack of RCT evidence. Determination of prominent study of pemafibrate, which significantly reduced TG, does not necessarily imply that all TG lowering drugs will not benefit. Whether lowering TG can have CV benefit essentially depends on the amplitude of reduction in TRL, remnant cholesterol, or ApoB. Based on the limitation of clinical trial enrollment conditions, current guidelines or consensus and statement recommended the prescription of omega-3 fatty acids to reduce CV risk has not abandoned TG levels. To solve this problem, the design of clinical trial related to omega-3 fatty acids in the future needs to fully strip away their TG lowering effect and other multiple effects. Thank you very much for